Cardiogenic pulmonary edema functions as a time-critical syndrome where survival depends on immediate physiological action. Success in the acute setting relies on rapidly identifying the patient's hemodynamic profile. Following a standardized, habit-based routine without addressing the specific physiology often closes the window for recovery before it ever truly opens. A 68-year-old male arrives in severe respiratory distress. His oxygen saturation is 82% on room air, his blood pressure is 186/104, and early labs show his creatinine is rising from baseline. We have to establish immediately if this is cardiogenic, and if his phenotype is hypertensive wet or cold wet. Patients face high in-hospital mortality rates and a significant risk of readmission within 30 days. These statistics dictate a need for immediate intervention. Every minute of delay increases the likelihood of a poor outcome. The decisions made in these first 10 minutes will determine whether the patient stabilizes or enters an unrecoverable clinical decline. Hydrostatic pulmonary edema occurs when the pulmonary capillary wedge pressure crosses the critical threshold of 18 millimeters of mercury. Once the pressure breaches that 18 millimeter mark, it overwhelms lymphatic reserve. Fluid is driven directly out of capillaries into the alveoli, compromising gas exchange. The bedside team must distinguish pressure-driven cardiogenic edema from permeability-driven mimics like ARDS. Diuresis provides little benefit when the primary issue is a permeability injury. The Noria-Stevenson matrix organizes the bedside assessment by mapping the patient on two axes, congestion and perfusion. Most acute patients are warm-wet, meaning they are congested but perfusing organs. However, risk rises significantly in the cold-wet quadrant, where congestion is complicated by systemic hypoperfusion. Hypoxemia triggers a neurohormonal cascade, resulting in a catecholamine surge that increases systemic afterload. This forces the heart to work harder against rising resistance, which further elevates left-sided pressures. Identifying the hemodynamic phenotype within the first hour is the only way to intercept this sympathetic spiral and protect the myocardium from exhaustion. Age-adjusted NT-proBNP thresholds help confirm heart failure when the clinical presentation is ambiguous. These values require careful interpretation. A high BMI can artificially lower peptide levels, while renal dysfunction often elevates them. The numbers must be integrated with the clinical picture. Point-of-care ultrasound and an immediate ECG provide actionable data at the bedside much faster than waiting for a formal chest X-ray. The ECG is a tool for identifying ischemic changes or rapid atrial fibrillation. These are the mechanical and electrical triggers that actively drive the edema. A formal echocardiogram becomes the urgent priority if you suspect a mechanical catastrophe, acute valvular failure, or right ventricular strain. Invasive monitoring, such as a Swan-Ganz catheter, should be used selectively. It is indicated for refractory shock or cases where the diagnosis remains unclear despite bedside assessment. Imaging and labs are used to identify the precise trigger, but they should not delay the initiation of offloading therapies. This clinical pathway branches based on the patient's physiology. Treatment is determined by the specific hemodynamic presentation. The hypertensive wet branch requires 3 rapid interventions: non-invasive ventilation, intravenous vasodilators, and diuretics. Non-invasive ventilation, such as BiPAP, should be started immediately. It reduces the work of breathing and improves gas exchange, which can prevent the need for intubation. For patients with a systolic blood pressure over 110, intravenous vasodilators like nitroglycerin rapidly decrease both preload and afterload. A frequent clinical error is underdosing loop diuretics in the first hour. Diuresis is most effective when the initial dose is aggressive. According to the dose trial, the initial intravenous furosemide dose should be at least equal to or double the patient's home oral dose. In the hypertensive wet phenotype, vasodilators and ventilation resolve the respiratory crisis much faster than the kidneys can remove fluid. The management priorities change for the cold-wet profile. These patients have poor systemic perfusion, meaning reflex diuresis can worsen their condition. Cold-wet patients require immediate perfusion support. Inotropes like dobutamine or milrinone augment cardiac output to restore organ function before significant fluid removal is attempted. If pharmacological support fails to stabilize the patient or lower lactate levels, the team must consider early escalation to mechanical circulatory support. It is also important to recognize flash edema as a rapid redistribution of fluid from the venous system into the lungs, rather than an increase in total body fluid. Right ventricular failure is a specific complication that can be easily overlooked. Aggressively dropping preload in a patient with RV failure will collapse their filling pressures and crash their cardiac output. Mistaking fluid redistribution for total body overload or missing RV failure can lead to treatment errors that increase mortality in salvageable patients. ICU triage is based on a failing clinical trajectory. Persistent hypoxemia despite non-invasive ventilation or rising lactate levels indicate the need for higher-level care. Residual congestion at the time of discharge is a primary driver of 30-day readmission rates. Evidence from recent clinical trials is narrowing the gap between acute stabilization and the start of long-term therapy. The MPulse and STRONG-HF trials show that starting disease-modifying therapies during the hospital stay drastically improves survival over the next 90 days. A transient rise in creatinine during aggressive diuresis is a common hemodynamic shift. This should not automatically lead to stopping diuretic therapy if congestion is still present. The hospital admission provides a critical window to initiate the neurohormonal blockade that will determine the patient's long-term survival. Let's return to the 68-year-old male from our opening case. The patient survived because the team correctly identified the hypertensive wet phenotype and acted immediately, rather than waiting for lab results to confirm the diagnosis. The intervention matched his physiology: early ventilation to assist breathing, IV nitrates to drop his blood pressure, and an appropriate diuretic bolus. Management of pulmonary edema depends on these priorities. Identify the phenotype, start ventilation early, use an adequate diuretic dose, vasodilate if the blood pressure allows, find the trigger, and optimize long-term therapy before discharge. This grid summarizes the 4-pillar framework for discharge optimization. Establishing the 4-pillar regimen, ARNI, beta blocker, mRNA, and SGLT2 inhibitor, is the final step of acute care. Improving outcomes in pulmonary edema requires replacing clinical hesitation with phenotype-driven speed. Thank you. We will now begin the Q&A.